So, good afternoon, everyone. My name is Dr. Melissa Bouchard. I'm a cardiologist specializing in congenital heart disease. And I'm the founder of the ACHD Hive, an educational platform for ACHD. And today, on the episode of ACHD Hive Talks, we're going to talk about Fontan, physiology, and its failings. The first part, we will have a session presented by Professor Alex Van de Bruaene. And then after that, we will have a discussion with our experts of panelists, and that's when we'll welcome the participants to ask questions, share their opinions and thoughts. Just a little bit of housekeeping before we start. We'd love you to have all your videos on so we can see who we're talking to. Audio's on mute, please, in the first half of this session. So, with further ado, please welcome Professor Alex Van de Bruaene for a presentation on Fontan. Alex, over to you.
Thank you, Melissa, for the kind introduction. Thank you also for the kind invitation on this new and exciting initiative in the field of congenital heart disease. Everyone can hear me fine? That's okay? Perfect. And so don't hesitate. So the idea is education, is if I understood correctly. So don't hesitate to interrupt me or to ask questions either during or after the talk. That's all fine. So for the next 25, 30 minutes, I'll be talking about Fontan physiology, Fontan circulatory failure, when the house of cards comes tumbling down, as a subtitle, because that's more or less the idea we got when we see patients in clinic, especially in the ACHD clinic. Let me see how I can proceed. I have no conflicts of interest regarding to this talk, and the aims of the lecture, I divided them a little bit into discussing Fontan physiology at rest and during exercise, because that's what I like doing. Also discuss a little bit the long-term attrition of the Fontan circulatory failure, and then the big question, how can we implement this in clinical practice, or how would I implement that in clinical practice? How would I identify weaknesses and flaws prior to full Fontan circulatory failure? So just a bit of background, and I suppose everyone logging in will know this, but the Fontan palliation has been devised by Professor Fontan in 1971 for patients initially with tricuspid atresia, but eventually with one single functional or anatomical ventricular chamber. So for patients with tricuspid atresia, but later on also for pulmonary atresia and intact ventricular septum, unbalanced AVSDs, double inlet left ventricles, and most recently also for patients with hypoplastic left heart syndrome. It's important to know that the initial Fontan palliation described in 71, which you can see here on this slide, is not the Fontan palliation that patients nowadays undergo, but as ACHD specialists, we need to know a little bit of the history of Fontan palliation, because we do see those patients, all different kinds of patients in clinic. So here we have the classic Fontan palliation, where you see a classic Glenn with an SVC connected to the right pulmonary artery, where you see that the IVC goes to a closed right atrium, and then through the right atrial appendages connected to the left pulmonary artery. You also see that, interestingly enough, Dr. Fontan put two valves inside and closed the ASD. That is obviously not the type of Fontan we see nowadays, where you see a bidirectional Glenn connected to both PAs, and where you mostly now have an extracardiac conduit, 18 millimeter conduit connecting the IVC as well to the pulmonary arteries. So there's lots of things to talk about if you think about Fontan physiology and the consequences of Fontan physiology, and you can talk about the clinical presentation of patients with Fontan physiology, and we'll discuss a little bit about that with regards to exercise limitation, renal dysfunction, and so on and so on. I think interesting, like if you construct a Fontan circulation, there are consequences for cardiovascular physiology, the absence of a subpulmonary pump, the connections, how that causes power loss. And there's obviously also a lot of basic science biology that would be of interest, the consequences of that altered physiology on biology, which I will not discuss today. Also the comorbidities in terms of liver dysfunction, renal dysfunction, and lymphatic problems I will not discuss today, because that would take us hours and hours, and we don't have that time. So if we take a step back and think about a normal biventricular system, There we have a left ventricle, we have a right ventricle, two energy sources supporting the systemic circulation and the pulmonary circulation respectively. And that creates some boundary conditions. So the cardiac output can increase up to 5-fold. The aim of having a right ventricle below the pulmonary circulation is to keep right atrial pressures low. We also have pulsatility in the pulmonary arteries, and we maintain, obviously, an aortic saturation above 95%. That all changes a little bit when we go to a single ventricle system in patients with a Fontan circulation, where we see that resting output is probably a little bit less, although in the Fontan patients I see, it's probably not as low as 50%, but the increase in cardiac output, as we discussed, does not increase as much as it does in healthy individuals. We also see that by definition, we now have elevated systemic venous pressures and obviously no, or at least decreased pulsatility in the pulmonary arteries. And although in some patients, in most patients, the aortic saturation vary between 90 and 95%, we do have patients as well with persistent fenestration, with collaterals, who will have lower systemic oxygen saturation. And my colleague, Professor Gewillig, who you all know, likes to call the Fontan connection here the Fontan portal system. He thinks about it as a dam that you put in a river, causing upstream congestion and downstream decreased output. I think that metaphor more or less catches Fontan physiology, although it probably isn't exactly precise to cover all of Fontan physiology. But he did amazing work in Great Ormond Street already 45 years ago, and this is computational fluid dynamics avant la lettre, I would say, where he evaluates in this Fontan portal system and looks at pressure loss according to increase in flow. And then, as you can see here, depending on different degrees of stenosis or obstruction in the Fontan conduit, and also in terms of different cavities that you may have in this Fontan portal system, a right atrium, for example, you see that your pressure loss will increase. The same is true depending on the type of corners that you have, and depending on having pulsatility or not having pulsatility in the Fontan circulation. And this very preliminary work was actually the basis of implementing a TCPC instead of a classic right atrial to pulmonary artery connection at the time in the early 1990s. So very interesting work that continues up until today. If we think about Fontan connections, we also think about optimizing those Fontan connections in order to decrease energy loss. And you can have energy loss in different ways. You can have LPA stenosis typically on a longer or a shorter segment. You can have the angle of the connection of your Fontan conduit to the PA that is suboptimal, and you can have like your IVC conduit that is maybe a little bit too small. And we especially are learning that for those extra cardiac conduits, that it's not all good stuff. In contrast to the older lateral tunnel Fontans and RA2PA Fontans. So this is, for example, very elegant and interesting work from Friso Rijnberg from the Netherlands, where he saw that if you have pressure loss or in a small conduit or a suboptimal angle, that actually the congestion of the liver, which we care about a lot nowadays in patients with a Fontan circulation, is higher if your Fontan conduit is too small, if the angle is perpendicular instead of being slightly off to the pulmonary artery. So the work that was initiated so long ago at Great Ormond Street, that was the basis for the TCPC, is still continuing, still optimizing those Fontan connections in order to decrease pressure loss at the level of the Fontan portal system, or the Fontan connections, if you will. So there's also this thing about creating the optimal Fontan. I'm not going into detail because it's the work of the congenital surgeons and also the pediatric cardiologist. But if you go from the pre-Fontan state, where you have a palliative shunt to the Glen and then the Fontan system, this is the time where you can actually make those pulmonary arteries still grow a little bit and create the optimum pulmonary vasculature that you want in a patient with a Fontan circulation, because you want the pulmonary vascular resistance to be as low as possible without damaging the ventricle when that ventricle sits in a Fontan circulation. If you're here, you're a little bit preload insufficient, and that is when it's impossible to make those pulmonary arteries grow. Obviously, as adult congenital cardiologists, that's not what we're dealing with. We get those patients from the pediatric department, and that's how they are constructed. But still, it's worthwhile going back into the files, looking at how those Fontans were made. If we think about Fontan physiology at rest, it's very intriguing. So we take away the subpulmonary pump, and we just need 15 millimeters of mercury to keep the pulmonary vasculature patent. And Fontan patients actually do that with mainly passive and weakly active forces. That is just peripheral muscle contraction, bringing the blood back to the pulmonary arteries, respiration, sucking the blood into the pulmonary arteries. And on the other side of the pulmonary vasculature, maybe even the downward displacement of the AV valve contributes a little bit to having this 15 millimeters mercury to allow transpulmonary blood flow. The thing is that if you look at a Fontan patient at rest, he looks and feels more or less the same as you do. But if you put that Fontan patient on an exercise test, you see the difference. And it's during exercise that you can actually increase that signal to noise ratio and actually stress the difference between Fontan patients and controls. And this is some of the work we did at the time when we were putting Fontan patients in an exercise CMR, and we calculated end-diastolic volumes and systolic volumes, cardiac outputs, and had pressures as well. You can see that at rest, your cardiac index is actually very similar between controls and Fontan patients, but as they exercise, you see that those curves actually are not the same, and that your stroke volume doesn't increase, and he actually starts to drop earlier than you would expect in a normal circulation. The heart rate doesn't increase as much. However, if you look at the heart rate relative to the increase in oxygen consumption or workload, the slope is actually a bit steeper. So this phenomenon of chronotropic incompetence or decreased chronotropic reserve is still quite controversial. There are definitely patients with a Fontan circulation with chronotropic incompetence, but in the good Fontan patients, I'm not so sure if that's actually the reason for their exercise tolerance. So anyways, that was a very short bit on physiology, but what you end up is something that looks like this. So you have your systemic venous blood that is connected directly to the pulmonary arteries. We increase the systemic venous pressure a little bit to have that 50 millimeters mercury, to have transpulmonary flow, to fill the ventricle, to increase cardiac output during exercise. But elevated systemic venous pressures in all Fontan patients, by definition, and a slightly lower cardiac output, especially during exercise, those are the two hallmarks of any Fontan circulation, but also the root cause of any issue that you'll see later on in those Fontan patients, be it plastic bronchitis, issues with pulmonary vascular resistance, issues with Fontan-associated liver disease, issues with chronic kidney disease, and issues with protein losing enteropathy. So how does a Fontan circulation fail? That's a difficult question. This is data from our center, but I could have taken data from the New Zealand and Australian registry as well. But this is how the curve mostly looks like. Like it's an excellent survival during childhood, and then here you see this. There's like a break in the curve, and probably if you would continue that into adult age, you would see the same thing. So my colleagues from the surgical department, they did a stepwise approach in determining the mode of failure in those Fontan patients, and they defined obstruction, systolic dysfunction, AV valve regurgitation, high PVR, and then by exclusion also restrictive physiology of the ventricle as potential causes. If you take this a little bit further, and this is data from Brompton, a very nice paper from Gerhard Diller at the time, already 10 years old, so maybe time for some updating. But if you look at the at the expected risk of 5-year risk of death for a 40-year-old patient, you see that our Fontan patients actually do worse than patients with complex congenital heart disease in general, or even Eisenmenger physiology. So that's actually quite surprising. So we get signals from the pediatric department saying, look, we're really good at this. Patients do fine. Look at our survival curves. And then we look in the ACHD clinic, we look beyond the age of 40, and we see a lot of issues coming down. And then obviously there's lots of reasons for this. There's the anatomical complexity. If you have a hypoplast, it's going to be tougher than if you have a tricuspid atresia patient. There's issues relating to constructing or building the Fontan circulations. If your pulmonary artery size, for some reason, you have a pulmonary vein obstruction, that's an issue. But there's also environmental issues. Some patients are not as fit or less inclined to be as fit as other patients. There's socioeconomic status that plays a role. And obviously along the way, there's disease complications related to the ventricle, the valve rhythm, maybe also the pulmonary vasculature, and then eventually in a lot of those patients also end organ damage that plays a role. We all are dealing now with Fontan-associated liver disease, becoming hepatologists along the way. I think renal dysfunction is gaining importance, and then in some patients we also have lymphatic issues that can be quite dramatic. Obviously, if you see a patient in clinic, the most common complaint will be that they can't do the same amount of exercise as their peers, or that they would like to be more active and that they can't. And indeed, if you look at the values of peak oxygen consumption, I think this is all data again from the Brompton, you see that Fontans, although not being the worst, they don't have a normal percent predicted peak oxygen consumption, and usually hover around 55 to 60%. So either we consider this decreased if we compare it to healthy controls, or we consider it normal for a Fontan circulation. If you then compare the different types of Fontan circulation, then they're more or less the same, which is understandable if you think about the changed physiology. But it's important to stress that even in a Fontan patient where cardiovascular physiology is very different, is that the reasons of not being able to do the same thing can be multifactorial, right? It can be related to the heart, it can be related to the lungs, it can be related to the muscles, it can be related to collaterals, anemia, the deconditioning, and so on and so on. So I think it's important, if you see a patient, to look at the whole package, because if you just consider the vasculature or the heart and don't consider the other things, it can lead to inappropriate or not treatment, affect prognosis, and above all, lead to frustration for both the physician, the treating physician, and the patient. So imagine if we have this patient in clinic, like the ideal testing modality would be an exercise cardiac catheterization, and if we could maybe also combine that with an MRI. Obviously, this is wishful thinking. Our colleagues at Mayo have done phenomenal research on this, and I think they've done more than 100 exercise cats in their patients, and I was happy enough to collaborate with them, and they've defined. So in one paper they looked at, like, are there cutoffs that we can use where it looks like we should look a little bit further and try to understand why their peak oxygen, why their exercise capacity is not good enough. So they define certain cutoffs at rest and during exercise, which they considered abnormal. And if you have a peak oxygen consumption below 50% and a low peak heart rate, probably these are worse Fontan patients, and it may be valuable to do some additional testing in those patients, maybe invasive then. So what I think is interesting, they also looked at the changes in pulmonary artery pressure, or Fontan pressure, if you will, related to cardiac output. And if you see those changes, you can actually calculate the slope. So if you have a slope that is a more than 3 millimeters increase in pulmonary artery pressure per liter per minute increase in cardiac output, something is wrong. That's total pulmonary resistance. It's not really pulmonary vascular resistance, but it also includes the post-capillary component, your filling pressures on the other side. But be as it may, the steeper this slope, the worse the Fontan patient. And I think this is interesting. We wrote a little editorial about it because in that initial paper, they focused quite strongly on the pulmonary vascular response, which I don't think was all it told. And indeed, in maybe because of the editorial, I don't know. But they also, they compared their results they got in Fontan patients with results they also had in patients with a biventricular circulation, but HFpEF physiology. And as you can see, the wedge pressure increase in those Fontan patients was actually very similar to a HFpEF population. So I think where PVR obviously is crucial for making a Fontan, and in the immediate post-op phase, when you have a child and you just constructed the Fontan circulation, later on when they become adults, other factors may be at play, and it may be diastolic dysfunction of that systemic ventricle. I've got a couple of slides on pulmonary vascular disease because time is limited. I'll just go quickly through it because that got a lot of attention in the past because we had drugs that were pulmonary vasodilators and could actually work to open up the pulmonary vasculature, maybe improve filling to the systemic ventricle. So it made sense to test that in our population. And we've done the same thing 10 years ago. But there's also some arguments to see that to say that it's not exact that it's not exactly the same thing. There's some things that look similar. For example, there's endothelial dysfunction. There is a high expression of nitric oxide synthase and endothelin 1, which would be an argument in favor of pulmonary vasodilators. But if you look in detail, and there's an interesting article from Ridderbos from the Netherlands, in those older failing Fontan patients, the pathological changes you see in the pulmonary vasculature are not similar to the ones you see in pulmonary arterial hypertension, arguing against the use of pulmonary vasodilators. And this is that article. If you see early Fontan circulatory failure, you see indeed something that maybe resembles PAH, but if you see late Fontan circulatory failure, you see increased wall thickness, fibrosis, or actual loss of vascular smooth muscle cells in the medial layer, and that is absolutely different from what you see in PAH. So it's not necessarily said that those pulmonary vasodilator drugs do work in Fontan patients, which is probably why the trials, the FUEL trial and the TEMPO trial, so far the Rubato trial, have not been successful. I'll just skip this and move ahead just for time's sake. The question is now, if I see a Fontan patient in clinic, what should I do? Because there's lots of things to consider, but usually what we take history, clinical exam, ECG, echo, and exercise test, and that's done. Can we somehow change this to have a little bit more information? So this is one of my favorite patients. She's an extremely nice 43-year-old lady with just simple tricuspid atresia, transposed great arteries, VSD, ASD. She had a Rapa Fontan way back and then converted to a TCPC Fontan in 1999, also had an epicardial pacemaker in 2005. So your typical Fontan that you see in clinic, and she's struggling. It's like she's a New York Heart Association class 3 with SATs around 88%, normal blood pressure, and a regular, not a regular, but a pulse of 72 beats per minute. But she's already on quite some diuretics, as you can see here. Bumetanide 3 milligrams once daily, spironolactone. She's also on bisoprolol because she has atrial fibrillation. And I started her on empagliflozin, and we can discuss that as well. Some oral anticoagulation, amiodarone as well for her arrhythmia. She has, and I'll just restart this video. Can I do that? Yes, I can. So there's some mild AV valve regurgitation. Here you can see a persistent fenestration, right? And preserved systolic dysfunction. The image quality is poor, and I apologize for that. Probably it's my skill, or it's just the constitution of the patient. But if I put her on the biopsy, she did poorly, 36% predictor. Her VVCO2 was a bit elevated, and she also had decreased chronotropic response. She had a right heart cath, as she should have had. 23 millimeters mercury, a wedge pressure with that systolic function of 20 millimeters mercury, and a low transpulmonary gradient, I would say. Also, some signs of Fontan-associated liver disease, elevated BNP, and very poor kidney function. You can see the ECG there. So what else can I do to contribute to make her feel better in a way? And what we did 10 years ago was this, like we put patients in the exercise CMR, we had blood samples, we had pressures, uh, invasive pressures. And so we had excellent volumetric data, functional data, we had pressures. This is an actual Fontan patients in the CMR of 60-year-old, which is quite amazing. And then you get those images, and that's obviously what I would like in all of my patients. But when I call to the radiology department, they say, it takes a lot of time, a lot of effort to get patients through that test. So I couldn't do it. I couldn't do it, at least for all my patients. So what we started doing was exercising the patients and looking at the echoes during exercise as well. So we have gas exchange, we have the ECG, and we have the echo, plus we have a peripheral venous pressure measurement as well, giving us information on Fontan pressures at rest and during exercise. This is not the same patient because these are stills of another patients where you could actually see that the moderate AV valve regurgitation at rest actually increased to severe AV valve regurgitation at just 76 watts, where we could measure pressures in the peripheral veins, which should be the same as in the Fontan, and you can actually measure increases in cardiac output and stroke volume as well. It's reasonably reliable because we did inter and intra-observer measurements, and this is the setup. So here we have the Fontan patients on the table. We do the echo, we have the ECG, we have gas exchange, and maybe if you see here, there's a pressure line, and here you can continuously measure those pressures. Are those pressures an accurate reflection of Fontan pressures? Probably they are. So our colleagues at Mayo tried the same thing, where during their exercise cardiac catheterization, they also had a peripheral venous line, and you see an almost perfect match with an R of 0.9, and actually, so very, very good agreement with those pressures. We're quite confident that it's actually, in Fontan patients at least, it reflects those Fontan pressures quite accurately. We even see that then when we put those legs up, that the Fontan pressure increases a little bit and then comes down a little bit like this. It's a bit like a fluid challenge, really. What it does mean, we still have to evaluate, but it opens up possibilities to better assess those patients, and we can construct those pressure flow plots that we've seen from Mayo Clinic as well. And we're in the process of determining how it can make a difference for our patients. This is obviously still very research in the research arena, but you can also measure stiffness. So we do high frame rate imaging, and based on the frequency of this wave traveling in the myocardium, you can say something about the stiffness of the myocardium and also something about the filling pressures. And we have some preliminary data, it all needs to be confirmed, that if you have higher stiffness, that if you have higher values, that it correlates with lower peak VO2, with steeper slopes, with higher NT-proBNPs, etc., etc. So there's more stuff to come, just to have a more comprehensive, a more in detail assessment of our patients. And this is a bit the flow chart that I follow. So we put them on the exercise test. We look at the RER, right? Can they perform a maximal effort? Because if they if they did perform a submaximal effort, we need to think, why is that? Maybe they have knee pain, maybe they have anxiety, maybe there's other stuff. We look at peak oxygen consumption, that's just regular data that we have, but we can also, by calculating ventilation versus maximum voluntary ventilation, we can see if there's pulmonary limitation. And then we look at Fontan pressures. Are they elevated, yes or no? Yes or no, and the slope. If that slope is elevated, then we think, well, what is the reason for it? Is there systolic dysfunction, easily assessed at rest and during exercise, or diastolic dysfunction? A little bit more difficult. Maybe with those shear wave imaging, we can do it. Is there valvular regurgitation, or do we think there's pulmonary vascular disease, right? So that would be a cardiac reason for exercise limitation. But we can also assess chronotropic competence, changes in stroke volume, desaturation, and even peripheral limitation as part of this like comprehensive assessment of the Fontan patient. For our patient, we tried to decrease the antiarrhythmica, which didn't work. We tried to put her on levosimendan, which she didn't tolerate. We proposed her on our transplant reunion. She was declined because it was a triple organ transplantation, and we suggested a VAD, but she declined. So she's currently palliative and treated just in the outpatient clinic. So I think it's worthwhile thinking about making a dedicated Fontan clinic where you, a little bit different from your classic ACHD patient, you do a little bit more tests just to pinpoint the reason of be it exercise intolerance of your patients. And this CPET echo with PVP is just one idea I have, but obviously you combine that with blood work, CMR, liver imaging, and a lot of education and counseling for your patients. And I think those Fontan patients, they do deserve a little bit more time than the regular patient. So maybe just out of time to conclude, there's a responsibility of the pediatric cardiologist and congenital cardiac surgeon in constructing the best Fontan they can. You see that there's accelerated aging of the pulmonary vasculature due to a lack of pulsatility, but probably also of the ventricle, causing myocardial stiffness if there is no AV valve regurgitation and systolic dysfunctions. There's multiple etiologies to Fontan circulatory failure, and it's probably important to define that very well, especially since inappropriate treatment is not necessarily harmless. And I think we, as ACHD physicians, we're very good at waiting, but I think we should anticipate issues through knowledge of anatomy, interventions, and physiology, and anticipate those issues before overt failure occurs. Thank you so much. I hope it was a little bit in time, and happy to answer any questions.
Thank you very much, Alex. That was a wonderful talk. So we're going to move on to our second part of the session. Before this, I want to introduce Professor Magali Ladouceur, who is organizing the talks with me. So now on to the panelists. I'm going to let you guys introduce yourselves and we can start having a discussion.
Okay, shall I start introducing myself? So I'm Claudia Montanaro. I'm a cardiologist consultant, currently lead of the ACHD program in Rome at the Bambino Gesù Hospital. And I have been a lead of the Fontan service at the Royal Brompton Hospital up to 6 months ago.
Hello, hi, I am Rosaria Barracano, consultant cardiologist in the ACHD department in Naples, Italy. And I actually run a Fontan Day case, which is something like twice per month. And I trained at the Royal Brompton Hospital too, and works as a locum consultant cardiologist in the ACHD department in the Bambino Gesù in Rome as well.
Hi, I'm Raquel Prieto. I work in Madrid in Gregorio Marañón Hospital. I'm the lead of the Adult Congenital Heart Disease program here. I'm very, very interested in Fontan circulation. I'm very interested in failure of Fontan circulation and transplant and advanced therapies in these patients. Very, very interesting talk, Alexander.
Thank you.
Can I start with the discussion? Thank you, Alex. It was a remarkable presentation, and we are very honored to have you on Hive ACHD. One of my questions is, how do you evaluate diastolic dysfunction in single ventricle? Do you only use echocardiography? Do you have a cutoff concerning anti-proBNP, or do you, when you suspect diastolic dysfunction, do you systematically indicate right heart catheterization?
Excellent question, Magali. I don't have the answer. So I use all of the, I probably use a lot of the things you say. So the the classic diastole echo parameters don't correlate very well with invasive pressure measurements. There's the SD ratio, that the paper of Professor Lee that came out a couple of years ago. But if you look at the data, it's actually a quite small number. So I'm not so sure if it would hold up in a larger cohort of patients. However, then again, if you look at classic parameters, and if they would really mean a diastolic dysfunction, you see that those patients fare worse. So there's two sides to the story, but I don't use them particularly in clinic. I think this high frame rate imaging may be interesting, but it's still in the research arena and needs a lot of validation. I think it's a little bit of a diagnosis per exclusionem. Like you look, is there systolic dysfunction? No. Is there AV valve regurgitation? No. Then you have your Fontan pressure, and it's 25. Could it be pulmonary vascular disease? Often it's not. Then likely it's diastolic dysfunction, and then you refer those patients for a CAT, right? Just to confirm. Maybe you do even a fluid challenge during the CAT just to make sure that a borderline pressure is not missed as not, and that you miss diastolic dysfunction. BNP I use as well, because if you have an elevated BNP, it's probably not a good thing to have, but it's again not 100% watertight in Fontan patients. So I think it's a bit like you use different blocks in making the diagnosis. There's an index of suspicion that should be high. You can't use the classic parameters. The PVP helps you a little bit. If there's nothing else, the CAT should be done if you think of it.
Thank you. Maybe we have questions.
May I actually add a little thing? So first of all, earlier on I introduced myself, but I didn't thank yourself, Rachel, and Melissa for the kind invitation. And really, thank you very much. And congratulations to Alex for the very comprehensive talk on a topic that is not easy to discuss in 30 minutes. So really, congratulations. I very much agree with what Alex has said. And sometimes the diastolic dysfunction, I believe, even when the numbers are normal, can be detected with a fluid challenge during the cath lab. Sometimes we do see it very easily when maybe we do the right heart cath for the first time in an adult patient, because we tend to do it when they come to our adult service. So it's very easy to do, and it gives you prognostication. It gives you extra push for to treat the patient with diuretics. So I think it's a very important question you raised. Thank you.
So thank you, Melissa, first, and Alexander, congratulations, because your talk was very, very interesting. As you said, the knowledge of the anatomy is very important. So do you think there is a difference between patients with systemic right ventricles and patients with systemic left ventricles with Fontan circulation?
I think so. I think there is. I'm always puzzled when I look at a talk and it's Yves Dudechem who's the presenter. He says that there is not necessarily a difference between systemic RVs and systemic LVs, but I do think there is. In systemic RVs, you will have more issues earlier on. You will have more systolic dysfunction for sure. You will have more AV valve regurgitation for sure. If you have both, it's worse. And in patients with tricuspid atresia, like the one I showed, you'll see a happy functioning LV all the time, but it'll be a stiff one with diastolic dysfunction. So I'm pretty convinced that there are differences between the two in terms of mode of failure, as well as well as in prognosis and outcome, I think.
Yes, thank you. I do agree with you completely. 100%. Thank you.
I would like to ask you, when you receive a patient for first time in the adult clinic, so what's the approach for Fontan patients for you? So do you perform a cath lab just for reviewing, or now with the knowledge you have acquired, you wouldn't do that and wait for the exercise test results? We do a cath lab as a rule, and we are starting to do exercise cath. Our results, we find a lot of diastolic dysfunction, more than expected. And sometimes they come with vasodilators that are not so well tolerated, and sometimes you find that taking them away improves patients. So we are very seduced by cath with exercise, but maybe after talk we may change. I don't know.
So I think there's something to say to do a cath. Luckily, I must say, before the transition period, before transitioning to adulthood, our pediatric colleagues usually do the cath. They're in the same hospital, so I do have the numbers more or less, and that actually helps. So they don't associate me with. They just see me for the first time, and I immediately send them off for a cath, which can be a little bit annoying. Like, for your relationship with the patient can be sometimes quite tough. But I agree. It's like threshold for cath should be very low, and there's definitely a good reason to do that around the transition period. I let them go through so when they come to me the first time, I do a full assessment with the exercise echo, the CPET echo PVP that I mentioned, with liver assessment, with a cardiac MRI. And if there's anything that is out of the ordinary, or if I think that, for example, the conduit is a little bit too small, I have a low threshold to refer them to the cath lab. But then I have a little bit more data, a little bit more reasons to convince them, right? And I've started the conversation with my patients. Don't stop doing the exercise caths. I wish I could do it here, but it's logistically difficult.
Yeah, probably we are just learning right now what we can find, and maybe readapt our protocols. But yes, for now I find them very useful. But still, we do the whole examinations at the same time, obviously. Yeah.
Gianfranco?
Can you hear me?
Yes.
Okay, so thanks a lot. Very interesting topic. Gianfranco, I'm from Rome. I work in Rome. I'm in just a hospital. So I have a couple of questions and comments. First of all, in some of our patients, we have performed the cath study under MRI guidance. So in the MRI suite, we do obtain invasive pressures on both the right side and on the left side in order to put together the data from cath, so pressures and flows from MRI. And sometimes there are interesting results that we came with after this kind of study. This is kind of really starting experience, but we think it's useful, in particular in adult patients, where it is possible to perform all this procedure with the patient awake. It does not take too long, or does not add too much to the MRI evaluation. The analysis of pressures. And secondly, I would like to ask what is your approach with the conduits in the Fontan patients with extracardiac conduits? We are facing a situation where these conduits were implanted when the patients were very young, 4, 5, 6 years old, and in adult subjects, usually they look like being stretched or somehow even smaller than what was their size at the very beginning. our approach is quite, let's say, aggressive in some way, and we do try to kind of optimize the size, of these conduits to what is maximally achievable, because obviously these are, not, they cannot be enlarged without any limit. But our approach is, to optimize the size, eventually upsize from 12 to 18 or 20 even, in order to try to improve or the flow from the inferior vena cava, and potentially have a positive effect on the splanchnic venous flow.
No. So I agree. So it's difficult because we don't have real outcome data to do it, but we do it as well. And it's interesting. For example, last Friday we had a lady. She was, I think, 19 years old. Percent predicted oxygen consumption 100%, super Fontan. I looked at the conduit, 18 millimeters, looks fine, but still we send her for optimization. And if you look on both directions, so one was, I think, 17.5, but on the perpendicular projection, you only had 13. So you just be aware that not because in one view that it's normal, that in the other view it's the same. And we opened that up to 20 millimeters. There's an interesting study from Friso-Reinberg, and there is some, and I'm looking forward to that discussion. And there is a conference in Toronto, ACHD Toronto in June, where there will be a whole session of, should we go back to the lateral tunnel for exactly that reason? Because all of those extracardiac Fontans are probably a bit on the small side. Another one that I remembered was that like he was doing well, not that Fontan patient was not particularly doing fine, but also I noted his Fontan conduit is a bit too small. So I sent him to the cath lab to optimize it. And the first injection, that like he had a huge alcygos vein, probably because his conduit was too small. So I think we have kind of like an issue there with the extracardiac conduits being probably in most cases too small, causing probably a little bit more liver dysfunction, although the data to make this, to substantiate this, is still accumulating. But we're quite aggressive too. The only caveat is, so when I send then a patient for transplant, my surgeon is not necessarily happy with the stent. So that is something to think about, because of the to make the connection, and can be an issue.
Okay, thank you.
Claudia?
Yeah, thank you. So just to change a little bit the topic from the diastolic dysfunction in liver, may I ask Alex, what is the approach in your center for patients with AV valve regurgitations? So we know that, there is a possibility in adults, of course, to treat them when there is, for example, an aortic regurgitation and maybe severe aorta dilatation. Then, of course, a high risk or relatively high risk operation in a way is justified. What is your approach in your center for AV valve regurgitation in Fontan patient, and then I might say what we do.
That's a tough question. I must say the experience is quite limited here in terms of like dealing with AV valve regurgitation other than supportive. Luckily, the amount of patients is not huge with truly severe AV valve regurgitation. I remember one case that we discussed for transplant wasn't feasible, and then unfortunately the patient died. We have a few patients that underwent plasty at the time of conversion of the Fontan, and I think the success of the conversion was more in dealing with the valve than in dealing with the RA to PA to TCPC Fontan. But you have these transcatheter options, but I must say here that experience is quite limited. And I actually want to throw the ball back and maybe ask your experience, because maybe you have more experience with dealing with those patients.
Well, I think it's not a simple thing to deal with, as you correctly said. I can tell you that when I was at the Brompton, we were actually offering an operation to patients, to adult patients, even in those who were in NYHS class 1, but with a really severe AV valve regurgitation. This is because we know that in perspective, it's not good. It does increase the pulmonary pressure, etc. So our thought behind that was that if we operate them when they are well, probably the surgical outcome also can be better. But of course, to accept an operation when a patient is completely well, it's not that easy. Here in Bambino Gesù, let's say the ideal approach is the same, with the difference that very recently we have performed our first clip. And I mean, Gianfranco was the operator, can say something more, but I would say it was an extreme success for the patient. Because it started with severe AV valve regurgitation, and it ended up, after 3 clips, ended up with trivial regurgitation. Now, very early stage, I have to say, you know, surgically you can do different type of strategy, you can have different type of strategy, but we hope that that can be an option. Of course, the patient was highly selected, the anatomy was favorable, the jet was single, it was a morphological mitral valve, so a lot of positive anatomical factors there. But I think we should, at least among us, we should start speaking about that, because this is an option, and you know, that we have to put on the table for the patient.
Very interesting.
Rosaria?
Yes, thank you. This is a question for Alexander, but basically for all of us. What do you think about studying the lymphatic circulation in Fontan patients? Because, I mean, PLE is an important problem, which increases the morbidity a lot in these patients. And sometimes I think that we recognize PLE when it's really too late to do something, you know, significant for our patients. So what do you think? What do you do in your daily practice?
So PLE is indeed a tough one. I remember, so the one of those seminal papers on PLE and outcome is actually from Luc Mertens when he was still in Leuven, showing a really bad outcome. I don't think for the PLE, that contemporary PLE, let's say, that we have the same outcome, although it's very annoying to treat and always seems to come back. I think it's important to study PLE. I screen for it once in a while, obviously looking at albumin all the time. If there's complaints, maybe also do a stool collection and things like that. And when they have PLE, we do have some imaging methods available now to assess with CMR a dynamic lymphangiography and see whether we can see any issue on the lymphatic return, because probably there's a couple of issues possible, like a ductus thoracicus that has been ligated during one of the surgeries, or just lymphatic overload as the cause. But it's not that I do that MRI in all of my patients. There's something to be said just to learn from it again. But then again, there's always in the balance, like how there's a lot of tests that those patients undergo every time when they see me, and probably there's also a limit to their tolerance level when you say, oh, we'll also do an MR lymphangiography. I need to be able to convince the patient and myself that it has a consequence, to that. If I just say it's just to look and we'll maybe know in 5 years what we'll do with it, it's not good enough. If I say I do it because then I can see liver cancer and treat you, well, that's a good reason, right? So it's the lymphatics is a very interesting topic of research. I think it's really important, and in some patients it's dramatic. The consequences. We do have some treatment options, which is also a topic of discussion. But I don't check it as part of my routine in all my patients.
Yes, same for us. But I'm just wondering, should we do it before PLE? This is a tough question. I don't have an answer actually, because as you said, the patient may be not that compliant.
So it's mainly from Cincinnati, Dori's team that generates the evidence on this topic, and that's on the pediatric side, and he says that if you look at those CMR images prior to Fontan completion, you can say something about the success of Fontan completion. So it makes sense to do it at that point. Maybe if we image it now and we see different stages, you can say something about prognosis, and then it makes sense to add it to the protocol. In a study that we're doing, there is one image that we take, but I haven't looked at the results yet, just as to add it into the mix of prognostication, and I have to discuss with the radiologist in terms of this adds 5 to 10 minutes of scan time. Can we do it? Can we justify this?
Can I just say, I think, Alex, you were spot on when you said that we have to understand if we are speaking about pediatric pre-Fontan or adult cohort. I believe Dr. Rosaria was, of course, referring to adults. And in our practice, we do it when, after looking at albumin and protein. We never do it if there is not a clinical indication, because otherwise it's an acquisition that stays there. And what you do with that, you just repeat after X number of years. But I have to say that in this patient, we do then go ahead with embolization of lymphatic. And it's interesting because just in these days, there is Dr. Dory from Philadelphia in our center performing some of these cases in our Fontan patients. So I think, it's something that has to be taken in account. But as you said, our patients already undergo a lot of exam. So let's try to focus the test for the right patient.
No.
Thank you all. We have to conclude. I thank all panelists and Alex for the presentation and the brilliant discussion about Fontan and failing Fontan. I'm happy to know that we have much to do to improve the management of our patients, and I'm sure that many solutions will come from all of you, because you give an excellent discussion today. Thank you all.